You have lumbar stenosis and you've tried the ibuprofen, you've done the stretches you found online. Maybe you've gone to physical therapy and it didn't seem to help, or it actually made things worse. And somewhere in the back of your mind, there's a story that you can't shake. A relative who had back surgery, a friend's husband whose recovery was brutal. So you're searching for anything, literally anything that might fix this without going under the knife. I want to tell you something honest about lumbar spinal stenosis, and I want to tell it to you before I tell you anything else. If you've searched how to cure lumbar stenosis without surgery, the honest answer is that you cannot cure it. But here's what most patients don't realize. You can absolutely live well with it. And the difference between patients who manage stenosis well for years, sometimes for the rest of their life, and patients who end up in my operating room mostly comes down to two things: doing the right things and avoiding the wrong things. That's what this video is about. Over the next 15 minutes, I'm gonna walk you through exactly what works for stenosis without surgery. First, physical therapy done right, and the mistake that's incredibly common in stenosis PT that actually makes things worse. Second, epidural steroid injections, what they actually do, what they cannot do, and how to know if they're the right call for you. Third, the things that get sold to stenosis patients that don't help, and the one common one that can actually hurt you. And finally, what a real complete non-surgical plan looks like, so you know what you should be aiming for. I'm Dr. Omar Ramos, a spine surgeon at Twin Cities Spine Center in Minneapolis, Minnesota. Most of my patients with lumbar stenosis don't end up in my operating room. They end up doing the things I'm about to walk you through. And many of them are still walking, still working, still doing the things they love years later without ever having surgery. If you do not need surgery, I'd rather you not have it. I wouldn't want it unless I absolutely needed it. So let's talk about how to make that the most likely outcome for you. Before we get into specific treatments, I need you to understand the framework, because if you don't get this right, none of the rest of this works. Non-surgical care for stenosis is not a cure. It cannot be. The bones in your low back don't shrink back, the ligaments don't thin out, and the arthritis doesn't go backwards. Once you have stenosis, you have it forever. Non-surgical care is a symptom management strategy, and it's a really good one for the right patients. Here's why that distinction matters. Patients who go into non-surgical care expecting to be fixed usually get disappointed. They try one thing for 2 weeks, it doesn't fix them. They try the next thing, that doesn't fix them either. And within 3 months, they've concluded that nothing works. But that was never the goal. The goal of non-surgical care for stenosis is this: keep you walking, keep you doing the things you love, manage the bad days, and slow down the rate at which your function declines. If you can do that, and many patients can for years, you've won. So that's not a failure, that's success. You're not trying to fix this. You're trying to learn how to live well with it. Okay, let's talk about what actually helps. Starting with the most important non-surgical treatment there is, and one of the most commonly done wrong: physical therapy. Here's the mistake I see all the time. A patient gets diagnosed with stenosis, so they go to a generic back pain physical therapy clinic, and they get put on a standard low back rehab protocol. That protocol almost always includes back extension exercises, arching your back, prone press-ups, things like the McKenzie protocol. Those exercises are great for some back conditions, but they're not good for stenosis. Remember from the last video, when you bend forward, the canal opens up, and when you extend, the canal closes. So if you have stenosis and your physical therapist has you doing back extensions all session, they're literally walking you through the position that pinches your nerves the most. No wonder you leave hurting more than when you came in. Here is what good stenosis physical therapy actually looks like. 1, flexion-based exercises. Things like seated forward bends, knee to chest stretches, and posterior pelvic tilts. The pattern is movement that opens the canal. 2, a graded walking program. And what that means is that you have a goal of cumulative walking distance over time. Not pushing through the pain, but stopping when you need to, and leaning forward to recover, then continuing. That cycle, repeated daily, builds tolerance. 3 is cycling, especially on a stationary bike, like a recumbent bike. Cycling is done in flexion, so the canal is open. Most stenosis patients can ride for half an hour comfortably, even when they cannot walk for even 10 minutes. That's not a contradiction, it's just that the canal is opening when you bend forward. 4 is core strengthening. A strong core supports a posture that doesn't aggravate stenosis. It also makes everything else you do safer. If you are seeing a physical therapist and they're not building a program around these principles, find someone who treats spine patients regularly. Now, let's talk about the treatment that gets the most questions in my clinic and probably has the most confusion around it: epidural steroid injections. Here's what an epidural steroid injection actually is. A pain doctor or radiologist uses imaging guidance to deliver anti-inflammatory steroid right into the space around the nerves in your spinal canal. This steroid reduces inflammation. That inflammation is part of why those compressed nerves hurt the way they do. And here's what an epidural injection is not. It's not a structural fix. You'll still have the stenosis. The injection doesn't shrink the bone, doesn't thin the ligament, and it doesn't reverse the stenosis. What it does is that reduces the inflammation around already compressed nerves, which can then give you a window of better function. For some patients, that window is week. For some, it's months. For some, the injection actually doesn't help much at all. If your injection works, that doesn't mean that you don't have stenosis anymore. It just means that the inflammation around your nerves is reduced, and that structure underneath is still the same as it was before. So use that window, do the physical therapy, build up the walking distance tolerance. The injection buys you the time to make progress that lasts. There's one more thing injections can do that doesn't get talked about enough. They can help us with the diagnosis. In patients that have multiple levels of stenosis, and many patients do, sometimes it's not clear which of the levels is actually causing the problem. So a targeting injection at one level can help answer that question, right? So if the injection helps at that level, then we know that that's the problematic level. If you have an injection at one level and it doesn't help, then sometimes we target another level to try and determine where the problem is coming from. So that information is important, particularly if surgery is being thought about, because you don't want to operate on the wrong level. So how many injections can you have? In general, most doctors limit it to 3 or so per year. The steroids can have a systemic side effects, especially with repeated frequent dosing. Things like bone density issues, problem with blood sugar in diabetic patients, and immune function dysregulation. If injections give you durable relief, great, you can keep doing them as needed. If they stop working or each one gives you less time than the last, that's information that is helpful. That's part of how we know when conservative care is reaching its limit. I want to spend a few minutes on this section because if you've searched online for stenosis treatment, you are getting bombarded with things that range from doesn't help to some things that could actually hurt you. I want you to know which one is which one. First category are things that get heavily marketed but don't have a lot of evidence for stenosis specifically. First one being inversion tables. The idea is that hanging upside down opens up the spinal canal. The mechanics aren't crazy, but the actual evidence for stenosis is thin, and there's a real risk for older patients, especially ones with high blood pressure or glaucoma. I don't actively recommend them for lumbar stenosis. Second one is stem cells or regenerative injections marketed as a stenosis treatment. There is no good evidence that these reverse the stenosis. They're often expensive, almost never covered by insurance, and the marketing is way ahead of the science. If a clinic is selling you a 5-figure regenerative package for stenosis, be very cautious. The third one is online programs that promise to cure or reverse your stenosis with stretches, supplements, or other lifestyle changes. The same anatomy logic applies. The stenosis is structural and it doesn't go away. A program cannot remove the arthritis of your joints. The second category, and this is the one I really want you to hear, something that can actually hurt you if it's done wrong. High velocity manipulation of the spine, the kind where there's a quick, forceful adjustment with an audible pop, can be problematic in patients with severe stenosis. The combination of compression and rotation of an already narrow canal is not ideal. I'm not telling you not to see a chiropractor. Many chiropractors actually use gentler techniques like flexion distraction that can actually be very helpful for stenosis. What I'm telling you is this: if you're seeing a chiropractor, let them know you have lumbar stenosis. Most of them will know what to do with that. Okay, let's put it all together. Here's what a real, complete, non-surgical plan for stenosis looks like. 1, flexion-based physical therapy, not just generic back pain physical therapy, specifically a program built around opening the canal, not closing it. 2, a daily walking program built around your tolerance. Lean forward to recover, then continue. And remember, the goal is increasing cumulative distance over weeks and months, not heroics in any one single visit. 3, cycling, a stationary bike or recumbent bike, ideally most days of the week. This is one of the best cardiovascular exercises a stenosis patient can do, and you'll often tolerate it far better than walking. 4, over-the-counter anti-inflammatory medications like ibuprofen, naproxen, but use judiciously. Talk to your doctor about whether they're safe for you, especially if you have kidney issues, blood pressure issues, or you're on blood thinners. 5, strategic epidural steroid injections for symptom flare-up or to give you a window to do the physical therapy and walking work that builds up lasting function. 6, activity modification, not activity avoidance. You don't stop doing what you love, you find the version of it that you actually tolerate. Shorter rounds of golf with a cart, hiking with poles, standing tasks broken up with sitting breaks. 7, if applicable, weight optimization. Even modest weight loss reduces the load through your spine and can meaningfully extend how well you do. Now, here's the most important part of the whole plan. The thing that tells you whether what you're doing is working. Track your walking distance over time. Not how you feel today or how you slept last night. Actually, how far can you walk before your legs stop? Measure it monthly and write it down. If your walking distance is holding steady or improving over months and years, then your non-surgical plan is actually working. Stay the course, you don't need surgery. If, on the other hand, your walking distance is steadily eroding and going down, that's information that is useful. That tells you something different is happening. That's not failure of conservative care. That's conservative care telling you it's reaching its limit. And what you do with that information is what we'll talk about in the next video. In the next video in this series, I'm going to walk you through exactly that. When does stenosis surgery becomes the right answer? What are the signs that you've gotten everything you can out of non-surgical care? And what do you do with that information? If this video helped you, the best thing you can do is hit subscribe and the notification bell so that you can see the rest of the series. And if you have a question, drop it in the comments. I read those questions and those questions shape the videos I make next. I'm Dr. Omar Ramos. I'll see you on the next one.